Good morning, everyone. I think it's time, so we will just start. So I see I can share my screen, but it looks like, I don't know why the screen I hope you can see the screen well. John, just can you confirm that you can see my screen, please?
Yes, we can see it perfectly.
Okay, because in my screen, it looks like there's something strange, but if you can see it, it's perfect. Okay, good morning, everyone. Welcome to the third event in the Lethe project webinar series. It is a pleasure to have you with us today for this exciting webinar, I guess, on AI. So we will explore the application of AI today from early risk detection to disease treatment. I am pleased to moderate this webinar today. So my name is Cindy Birk. I'm project officer at Alzheimer Europe. So it's an umbrella organization of 41 national Alzheimer associations from 36 EU countries. And our mission is to change perception, policy and practice of people living with a disease. We are a partner in the Lethe project, but also in all the projects that will be presented today. So I'm really pleased to be here today with all of you. Just some housekeeping rules before to get started. This session is being recorded and it will be posted on the Lethe project website shortly after the event. Please turn off your camera, mute your microphone, and we will also have a question and answer session at the end after all the presentation. So please use the chat function. You can ask questions there. And please be active. Do not hesitate to ask questions you may have to all our panelists. So the agenda for today, we have 4 experts with us. Each presenter will present the work of 4 EU-funded projects. So we have Lethe, AIMind, Prominent, and ADIS. And with this 4 presentation, we will learn more about AI, how AI is being applied in different stages of dementia research, with a focus on prevention, early diagnosis, and intervention. Each speaker will give a short presentation, then we will have a panel discussion, and we will open the question to all of you. For today, as I said, we have 4 speakers. We have Einar from the AIMind project from University of Oslo. We have Antti Tolonen. He is the senior imaging scientist at Combinastics. We have Sofia Quicks, PhD candidate at Fraunhofer Institute for Algorithm and Scientific Computing. And our last speaker will be Marcus from the Lethe project. He is a researcher at the University of Applied Sciences in Graz in Austria. So welcome to you all, and we are excited for today's discussion. And without further delay, I'd like to introduce our first speaker, Einar. He will kick off the session with a quick presentation on AI and present the aim and concept of the IMI project. Over to you, Einar, and I think you can share your screen now.
Thank you, and thank you very much for the introduction, and I'm happy to be here. I'll start sharing. There we go. I hope you can see that.
Yes.
Super. Thanks for coming, everyone. As Cindy introduced, I'll be talking about using artificial intelligence to understand and predict dementia. And for this series, Beyond the Hype and Dementia. So I'll be talking a little bit about hype, a little bit about dementia and AI, and specifically about AIMind. There we go. But as you might have guessed from our name, AIMind, we are trying to use artificial intelligence to study the mind, or perhaps a little bit more specifically, the brain, but the AI brain doesn't really roll off the tongue quite as nicely. However, we do want to understand and predict dementia using AI, as the name implies, and as you might have gathered from so far. But why do we actually want to use AI in this context? So artificial intelligence, even though that's in the title of the webinar, it's not just hype, even though there's a lot of it, nor is it just AI images with too many fingers or chatbots that hallucinate lies, as you've probably seen in the news quite a bit. So with proper usage, it does actually show quite great promise and does deliver real results in many areas, especially including the medical field. The thing is, though, that a lot of the time, the more robust the results from AI, usually the more specialized the implementation is, and the more well-defined the scope is, which is also the case for AIMind and for a lot of these other projects that actually show this promise. And as such, a good reminder is always that it's often good to not to try to solve everything, which is oftentimes the case for these big AIs. That means less hype, but it does mean that you might actually be able to deliver on those promises. But first, a lot of this time, these times when I give these talks for a bit more general audience, I learned that a lot of people are kind of unsure what AI actually is. So I like to start with this slide. And so artificial intelligence, for those who've never heard more or less the broad definition, it's actually just a catch-all term for machines performing tasks usually associated with human cognition or thinking, such as problem solving or reasoning. And that means that a lot of things that we don't think of as AI could be defined as AI. So if you just do an interpolation of data points on your computer, that can already be termed AI in a sense, even though most people don't use it in that sense. Machine learning, in turn, is just a subfield, just in quotation marks, of AI, and is usually characterized by algorithms that can be supervised or unsupervised, for those who've heard those terms before in this context, and reinforced learning methods, and they make inferences from data and solve problems, and are usually a bit the simpler kind, so to speak. Deep learning is usually the buzzword that's being thrown around today, right after artificial intelligence, and that's a subset of machine learning. And these are algorithms that sort of attempt to mimic the way that brains process information through what's called deep neural nets. Machine learning, as I mentioned, is pretty much any algorithm implementation of artificial learning and is often statistical in nature. And the question with the output from machine learning is often a bit more straightforward and more knowable than it is from deep learning, where you might have heard about the black box problem. On the side here is, for example, one of the most simple machine learning or AI algorithms, the K-mean classifier algorithm, where you literally just want to classify a new point and you just look at the neighbors, and whichever neighbors are closest and the most similar, you just classify it as the same. So machine learning can be very simple. Deep learning, in turn, we see a deep neural network on the side there with 2 layers only. But deep learning, much simplified, is technically, again, just a subset of machine learning, and it sort of tries to mimic neural networks of brains, hence the name. Deep learning have multiple hidden layers, as I mentioned, and are therefore called deep. And these multiple hidden layers are basically the source of the black box problem that a lot of people talk about, where you're not really sure what's going on inside, even though you get output. It's got a layered structure of algorithms, as I mentioned, and each of the nodes can represent a feature. So as deep learning algorithms learn, each of the different layers learn something, and each of the nodes can represent features that, for example, if you want to identify images, after a while it learns like these are eyes, these are noses, and in the end it combines into a face, for example. However, these are very computationally expensive and they have to be trained a lot, and data has to be passed through neural nets many times because they're sort of slow learners, which is probably also something you might have heard of. And that's why they typically require very large amounts of high quality data to actually be trained. Coming to AI Mind and how we're actually going to be using this or are using this. We're a consortium of 17 partners from lots of different sectors, so hospitals, companies, universities, and patients organizations. Got a budget of 14 million euros, and we've got a duration of 5 years and are funded by the Horizon project from 2020. And the entire sort of basis of the project is that we've got 1,000 participants enrolled with mild cognitive impairment in the countries of Norway, Spain, Finland, and Italy. We follow these participants over 4 visits over 2 years each, and following participants along as we are collecting data. We collect quite a variety of different data modalities. So we're collecting EEG and MEG scans, biomarkers, so protein markers and so on, cognitive scores, and social demographic information about all of these participants. We're deploying then a full AI Mind platform, so an entire software suite for both analysis of data and collecting it on the University of Oslo's IT department, secure and GDPR compliant services for sensitive data. Here we have secure uploads, storage, virtual machines, and high performance computing for the actual AI business. And the platform, as I mentioned, it takes care of everything from quality assurance of collected data. It includes a processing pipeline and contains our integrated AI and end user tools that will actually deploy at the very end. So, but why do we actually use AI in AI-Mind? So, and how are we actually set to leverage it as best as possible in AI-Mind? So given our field, we actually do have a lot of data. It's not as much as we see in like the big applications like for ChatGPT and stuff, but for the medical field, we do have quite a bit. And deep learning especially shines when you have different types of correlated data, which we have, as I just mentioned, and may find patterns that humans can't in such a variety and volume of data. Our data is also of high quality and highly standardized, which was a very big part of the clinical protocol when we set out to collect it. It's very ethically collected and with very strict consent, and we've securely stored it and processed it on TSD, as I mentioned. Furthermore, we've collected a big team across our different organizations from both neuro and medical science, AI research, software development, ethical oversight, and more. So we're very much poised from different fields, which is sometimes a headache getting everyone to talk together properly and understand each other, but it's very valuable in developing something like this that crosses a lot of fields. So AI-Mind's primary goals, which are very much simplified, and by a non-clinician, that is me, we've got two primary goals. One is to find the actual underlying features in the brain, which indicate whether someone living with mild cognitive impairment will progress to dementia, which means we want to understand dementia at a more fundamental level so we can find treatments. Or very much simplified, what causes dementia, which is ambitious, but that's what we're setting out for. And goal two is to be able to predict whether a specific person diagnosed with mild cognitive impairment will progress to dementia. And that will, of course, enable clinicians and people living with MCI to make informed choices about treatment options. And this even further simplified is, will you get dementia in the case of if we evaluate you with the AI-Mind tools? And goal one can be translated into one of our AI tools that we're developing, which we are developing primarily with machine learning, statistical kind. And here we're mostly analyzing the large data set of EEG and MEG brain readings of our participants with MCI. Here we then find features in the recordings that correlate with people progressing to dementia later as we follow them throughout the study. And we analyze these features to find the actual changes in the brain. And this is going to be solved by what we're calling the connector tool. And that's going to be primarily aimed at researchers who are trying to understand dementia and its effect on the brain, both in the consortium and later for others. Goal two is using our AI methods, which are primarily going to be deep learning in the second part, which will be trained on the data from the EEG and MEG readings, the cognitive test, the social demographic info, biomarker tests, and then use it to predict whether a given individual with an MCI diagnosis will progress to dementia for diagnosis purposes once it's actually at the medical device stages. So, and insights from the connector can also be used. So the stuff that we learn from the connector and the insights from the brain can also be fed into the predictor. And then we want, in the end, robust predictions with high accuracy and low uncertainty, of course. And that's going to be solved by the predictor tool. And this one is going to be aimed primarily at clinicians wanting to provide a prognosis for their MCI patients. And that's going to empower informed decisions by clinicians and patients together about potential treatment or mitigation plans and what the plan forward is if they have a high likelihood of progressing to dementia. And this is basically the AI-Mind concept summed up very briefly. We get EEG data and other data on the left side. It's fed into the AI-Mind connector first, where we get identification of disturbances in the brain network. That in turn is fed forward into the AI-Mind predictor together with the other kinds of data such as genetic test data, cognitive tests. And from there, we can also then get estimations of dementia risk for clinical decision making. And the overarching take-home goals of AI-Mind, then a bit summarized, is that we want a deeper understanding of the brain, how it changes with dementia, and that creates opportunities for new research and insights. And particularly, we also want to uncover unintuitive and novel features, which is what I mentioned with deep learning, where things that you might not correlate as a human might be more obvious to a deep learning algorithm, which you can then study further by humans. At the moment, we can only provide an impersonal statistical likelihood of about 50-50 coin flip for a progression rate from MCI to dementia within 5 years, which of course is not good enough given the rising cases of dementia and in our aging population that we're currently seeing. So what we really want to do is to deliver a beyond the state-of-the-art diagnostic tool to predict whether someone will progress to a dementia diagnosis. We want to do that with a more than 95% accuracy and high confidence, and we want to be able to deliver that in just days or weeks to a given patient. And that, of course, will then lead to hopefully opportunity for early interventions and more targeted treatments for those who actually need it and not those for who wouldn't even progress further onto dementia. So yeah, thank you for your time, and questions are welcome. I guess that's first from Cindy and then later in the panel. Thank you for your time.
Thank you so much, Einar, for this interesting talk. So I think we will just keep the question to the end. We will just go presentation by presentation. So please be active. If you have any question to any of our panelists, use the chat box. And I will just reshare my screen before to introduce the second speaker. So our second speaker, it's Antti Tolonen. He will discuss how AI and machine learning are being used in the Prominent project to advance precision medicine in neurodegeneration. I will just give you the control, Antti, now. So you should be able to share the screen.
Okay.
Please go on.
Thank you, Cindy, and thank you, Einar. So I am Antti Tolonen. I'm from Combinostics. We are a small company developing imaging tools for radiologists and then decision support tools for neurologists. And I will give a short presentation about the Prominent project. So what is the Prominent project? The Prominent project is a 5-year project where the aim is to develop a digital platform for dementia diagnosis and treatment. This platform is based on an existing digital tool, which is our Combinostics Neuro, which is in turn based on platforms developed in earlier European Commission projects such as PredictAND and PredictAD. So there's quite a nice continuum and history here. And once we have developed this platform, we will then assess it in 2 aspects. So one is how well it provides useful information for the users who are clinicians, patients, and care partners. And then since the platform will contain some diagnostic and prognostic models, we will assess how accurate these models are. So how well the predictions compare to clinical reference and standards, and then the actual outcomes of the patients. And at the moment, we are at the late stages of the platform development, and we are about to start these studies evaluating the usefulness and accuracy of the platform. So a little bit more about the digital platform and what will be developed into it in this Prominent project. So the platform will contain prognostic and diagnostic algorithms for dementia. So statistical models that predict the progression of the disease and what is the likely etiology of the disease. So is it Alzheimer's disease or dementia with Lewy bodies or frontotemporal dementia and so on. And then there will be models that will be used in assessing the eligibility for disease-modifying treatments. So this is anti-amyloid treatment for Alzheimer's disease. And then in this project, we will develop also new imaging biomarkers for ARIA detection and quantification, and ARIA stands for amyloid-related imaging abnormalities. So imaging findings that indicate potential side effects, harmful side effects of the anti-amyloid treatment. And then we'll develop new ways to represent the information for the users, clinicians, patients, and care partners. So there will be summary reports. These will be just simple PDF reports with the level of detail and the focus tailored for each of these user groups. And then there will be an interactive user interface, which is mainly targeted for the clinicians. So if they want, they can have a more detailed look into the data And then one aspect we will also develop is a framework for collecting data about the clinical decision-making process that can be then utilized by health technology assessment bodies to assess the effectiveness of different tests and treatments used in the dementia diagnosis. And then final aspect that I want to highlight here is that we will develop an integration to digital patient records so that test results would be automatically transferred to this digital platform, minimizing the manual work that needs to be done by the clinicians. And a little bit about the data sources and how we plan to utilize them in the development of the diagnostic and prognostic models. So we are collecting retrospective data from 8 different cohorts and then combine these two into one single development data set for the models. And we will use a combination of federated and centralized approach in the data management. So by federated, we mean that the actual data is not transferred from the individual centers to the central database, but only statistical information about the data is used. And centralized means that actual measurement values are transferred to a centralized database. And at the moment, it seems that we will be mostly utilizing this centralized database. So most of the centers are okay with transforming pseudonymized data to a central database. And since we are dealing with data from multiple different cohorts in different countries, we need to do some kind of data harmonization. So what we will do is that the imaging biomarkers that we will use in the model development, they are all produced by the same image analysis pipeline. And for other biomarkers, such as neuropsychological tests, we will try to harmonize different but similar neuropsychological tests, for example, by using population norm-based Z-scores and percentiles. And also we try to harmonize the diagnosis by relying as much as possible on diagnosis based on actual biomarker values instead of clinical diagnosis done in each of the centers. And then a little bit about the studies that we're planning to conduct in order to test the platform. So the first one is evaluate study, where the aim is to first develop a training program, and then there's a test how effective this training program is. So the training program is about how to use the digital platform and how to understand the information there. And the other objective is to systematically collect user experience and opinions about the use of this digital platform. And then we will conduct a second study called validation study, which will be a multi-region, multi-case study, where clinicians will retrospectively rate patient cases using the digital platform and without using the digital platform. And the study is done so that we will try to simulate the clinical decision-making process as close as possible. So the clinicians will be presented with the information in a stepwise manner. So they will, for example, first get simple neuropsychological test results, and then they will be asked whether they are willing to give a diagnosis at this point, and what would the diagnosis be, and whether they want to do more tests, and if they want to do more tests, what would this new test be. And this process is then continued. So, for example, after neuropsychological tests, maybe they want to take an MRI to be more confident about the diagnosis. And again, after MRI, we will conduct a similar questionnaire. And these assessments, as I said, will be done without access to the information from the digital platform and with access to the digital platform. And we try to estimate if there's a difference in diagnostic research use and confidence until the final diagnosis. And if during the project the disease-modifying therapies, meaning anti-amyloid treatment, are available at the clinics, then we will also try to study aspects related to that, such as accuracy of the eligibility ratings given by the digital platform and how accurate the risk assessments of the given by the digital platform are. And that's in very short the prominent study. It is a study with obviously multiple clinical and private sector partners. And thank you.
Thanks a lot, Antti, for your insightful presentation. I can see that we already have some questions in the chat. Thanks a lot. As already mentioned, we will address all the questions at the end during the question and answer session. So let's move to our next speaker. So it's Sophia Quicks. She will present how AI is used in the ADIS project, exploring digital sleep monitoring for early detection in Alzheimer's disease.
Yeah, thank you, Cindy.
Yes, and Sophia, just sorry to interrupt you. Oh, no. Sorry, I thought I was able to give you the control, but I will just share the slide on your behalf.
I will indicate, thanks. So warm hello to everyone. I'm really glad to have the chance to present some of my work here at the Lethe webinar series. My name is Sophia Quicks, and I'm currently pursuing a PhD in the AI and data science group at Fraunhofer Sky. So I will talk about the ADIS project, in which we are concerned with the early diagnosis of Alzheimer's disease, and we are exploring digital sleep monitoring for the early detection of Alzheimer's disease here. So next slide, please. In the ADIS project, we collaborate with several great partners from various disciplines, such as data science and AI, the biotech industry, and also clinical expertise, as we have our clinical partners in Barcelona, and public involvement. The project is funded by the JPND Neurodegenerative Disease Research, and it is ending soon, so I will be able to present you some preliminary results. And next slide, please. For our ADIS project, we saw that in the last couple of years, there have been several approvals by the FDA of several therapeutics for AD. And the problem that we're currently facing with Alzheimer's disease is that even though treatment options are available, the disease-modifying treatments, they're only effective if applied in an early disease stage. That means here the challenge is diagnosing patients as early as possible, which is in reality not easy, since diagnostic options have been either hard to access, are expensive, or invasive. The recent emergence of plasma biomarkers is very promising, yet these are only available in specialized centers. So we see an urgent need for additional low-cost and scalable biomarkers that can fill this gap and aid in accurate and early diagnosis of the disease. So what are biomarkers? What I'm talking about here, they are measurable indicators of a disease, such as molecules found in the blood or body fluids. And they're used in general in medical research and healthcare for diagnosis, prognosis, and monitoring of the effectiveness of treatments. So just to clarify what we're talking about here. Next slide, please. So in the project, we look into two aspects of the disease. On the one hand side, there's the immune system, where we see neuroinflammation as one of the main biological processes that is being increased and driven in the disease. We see interactions of cells within the brain with peripheral immune cells of the blood. And that made us look into a better understanding of the role of specific immune cell populations in the blood and their potential as early biomarkers which could be easily accessed via a simple blood test. On the other hand side, we look into sleep disturbances. And why? Well, because we see that such problems as nighttime awakenings, problems to get to sleep, etc., they are symptoms that appear early in the disease course. And that's why we think that we can evaluate these sleep disturbances digitally for the early diagnosis of Alzheimer's disease. Next slide, please. And here I will present you the part that concerns the sleep biomarkers of our project, since I cannot go into all of the aspects. What we did was to use data that were gathered in our ADE study from patients wearing smart devices. So as you can see here, this is a wristwatch. It is measuring actigraphy, and this actigraphy means movement data from the patients during the night. And we also compared this with historical data from another study, namely the Radar AD, where also a sleeping headband and another smart device were available. So what we get out of here are, on the one hand side, aggregated sleep parameters, so about how efficient the sleep was, how fragmented the sleep was, etc. But we also get time series actigraphy. That means we actually get the raw data of how patients slept and their movement. I will only go into the time series actigraphy data here, but we have conducted many more experiments. So next slide, please. We did time series actigraphy modeling. What is that supposed to mean? So basically, we took the time series data from the smart device, so meaning the wristwatch, which measures the movement, and additionally the light in the room, so since there was a light sensor. And we added demographic data about the patient's age, sex, BMI, etc. Then we used a machine learning classifier, which was able to get probabilities for each individual in the study to be diagnosed with Alzheimer's. And what we also did was to explain our predictions to avoid the typical black box of AI that Ida was talking about. And next slide, please. So here I am very happy to present you some preliminary results from our project. So this is what we found out. We can quite accurately identify patients with Alzheimer's using their sleep behavior and additional light data. In the left side, you can see on the right column, this is comparing control patients to patients with MCI, meaning mild cognitive impairment, and patients with progressed mild dementia. And you can see that we get a quite high accuracy of identifying patients. So on the right-hand side, we can now see how we make AI explainable. This is like looking into the heart of a machine learning model. What you can see on top is the movement data and the according light data on the bottom for just one night of a mild dementia patient who has mild dementia due to AD. And whatever time point is colored in red is what basically the machine learning model picks up and uses it for the calculation of the score for each patient. So we can see that in the top, the patient basically they woke up during the night, they moved a lot, and in the bottom you can see that the light switches. So every time there is a peak, they were all important for the model to learn from. And next slide, please. So these are quite interesting results that we then wanted to see and correlate whether the amount of sleep disturbances correlates with the physiological changes in the brain, namely reductions of brain volume, since we have MRI data. And this now is an example of the hypothalamus brain region, which in generally is important in REM sleep generation. And we see on the right side in the plot that the amount of sleep disturbances actually significantly correlates with the reduction in brain volumes as predicted by our machine learning model. And the correlation increases with progressing stages of the disease. Next slide, please. And last slide here. So what I can conclude with our results as of now is that sleep monitoring devices, they show huge potential for measuring digital sleep biomarkers for early AD, especially when modeling time series actigraphy data together with light data. And we also find a link between the disruption in sleep patterns and the brain reduction in the sleep promoting regions. And as I said in the beginning, we also look into the immune system. So we think that combining actually these both aspects, so sleep and immune system related biomarkers, they together have a huge potential to improve the early diagnosis of Alzheimer's disease. And with this, I want to thank you. And on the next slide, I also have my contact.
Thanks a lot, Sophia, for this really nice presentation on the ADES project. So finally, I am pleased to introduce our last speaker, Marcus from the Lethe project. He will be presenting the Lethe approach to dementia prevention and risk assessment. Marcus, you should have the right to control the slides, so over to you.
Yes, thank you, Cindy, for introducing me, and I'm happy to be here today as part of basically a homage in this webinar series, and want to give you some insights in our preliminary results in developing some prediction models in our Lethe project. Okay, so there's some delay in the. So basically, the Lethe project aims at developing a digital intervention framework for multi-domain lifestyle interventions, and the Lethe project is based on the well-known finger protocol, and we want here to complement this finger protocol by digital tools which were developed in kind of a mobile app for the study participants, and also we developed a clinical trial management system which is basically a web application or dashboard for health professionals. And this mobile application with wearable integration and this CTMS is basically the point where the data is collected and data comes into our system. And today we are not focusing on the digital tools, but on the development of some machine learning models for predicting the risk and progression of cognitive decline, which are focusing on the modifiable factors presented here. The data sources for within our project are basically coming from 4 different clinical centers. 3 of them are memory clinics, and 1 is the prevention trial from the Finnish finger study, and the other clinical centers are located in Italy, Sweden, and Austria. And here we have retrospective data which we harmonized in a data harmonization process, and basically this data spans from the scale of the disease progression from cognitive normal people over to subjective cognitive impairment and mild cognitive impairment to actually developed dementia. And this data or clinical information is collected and harmonized in our Lethe retrospective data set. And the Lethe intervention trial focuses on a small part of this disease progression trajectory, which is basically on cognitive decline or cognitive normal people. And you can see them on the left side here. And also within our study, we are collecting active and passive data from our study participants, which are spread over the 4 clinical centers. And in total, we have 160 participants. And here we collect the data from our mobile app in an active and passive way, and also from wearable devices, the devices in passive way. Okay, so this is basically the data we have, or we can work in Lethe. And today I will focus on the development based on retrospective data to put into use in our basically in our study. And the requirement for the model was, or for this first initial prediction model was to provide risk stratification based on baseline data with the further aim to provide an intervention initialization. So with this model, we want to initialize our intervention at the beginning of the study, or in general, the intervention. And here was the question, how can we model this risk of cognitive decline over a time span of the 2 years, which is our study duration. So regular measurements like the MMSE is basically not too sensitive for that. And therefore we switched to the NTB, which is a neuropsychological test battery, basically some cognitive tests. And the total score of this NTB was used to measure this cognitive decline, or assess this cognitive decline. And on the right here, you can see 2 patients, one with a declining NTB over the span of 2 years, and one with an increasing NTB total score over the span of 2 years. And in a subsequent step, we calculate basically the difference between baseline and one of the subsequent visits, and normalize it to the time. And this is our delta NTB, which will then be used to stratify between like the highest declining persons and like kind of low declining persons. So basically we have here some on the high risk level the persons with the highest drop in NTP, and in the low classification, basically the one with not so high or even increasing and delta NTP. And this data was used to formulate a supervised learning problem based on the finger data, and gives us basically the risk of cognitive decline over a time span of 2 years. And depending, or in a subsequent step, we progressed from not only predicting a binary risk like high and low, but also predict the let's say cognitive trajectory from baseline visit to the first follow-up visit and the second follow-up visit. And here you can see two model results, basically one using again the total NTP score over a time span of 2 years. And the other score used here is the LIBRA score, which is basically a lifestyle for brain health score, which uses only modifiable risk factors. And these risk factors are actually aimed at in our intervention. And in a subsequent step, this is also intended to extend with our digital biomarker data. And with digital biomarker data here, I mean our wearable device data and also the data collected from our mobile application. In order to provide some actionable information during the design or at the beginning of our intervention study, we applied some explainable AI framework like the SHAP framework or Shapefield Explanation framework to our trained initial prediction model. And here on the left, you can see, hopefully, for each predictor in the model, the contributing risk. So basically, a red bar here indicates a contribution towards a higher risk, and the blue bar indicates a contribution towards a lower risk. And in sum, this results in the risk prediction. And here you can get an explainable an explainable decision of the model. And as this information on single risk factor basis is quite overwhelming, as you can see here, we also spent some time in thinking about how we can differently present this information to the clinical to the clinicians. And there we came up with the idea to aggregate our risk factors per intervention domain, because in this intervention domain we want to intervene, and this is more important than focusing on single risk factors. And here we came up with such an aggregated version of this SHAP profile, where we can see basically the risk contributed to each of our intervention domain. And also, of course, we have here the differentiation between modifiable domains, and also here the general domain represents all the non-modifiable risk factor, which also play a role, but we cannot use to drive or to deliver our intervention. This SHAP framework also, or we are thinking about how this SHAP framework can also be used for kind of a simulation framework. As you can see here, again, SHAP explanation for one high risk prediction, or like a patient with predicted high risk. And here you can see for visualization purposes the BL score, which is a diet score, and this is on the low end of the range of this score, which means the diet of this patient is not good. So, and the question here we want to answer is, how can we improve this diet score, and what effect does this have on the risk prediction, so to say? And if we like simulate to improve this score to 9, which is the max in this domain, how does the prediction change? And in this case, it changed from a high risk prediction to a low risk prediction. And here you can see quite nicely that the diet score now contributes to reducing the risk, where it before contributed to increasing the risk. And so this is basically the idea we want to transfer in a simulation framework within our clinical trial management system. And together with this aggregated information, we want to put together this methodology and integrate it in our dashboard. And there we want to have basically a risk profile page for each of the participants, where you can see on the left side the baseline data, which was acquired during a baseline visit in the clinic. And here you can change some values and then look how the initial risk prediction will change, or how this risk prediction is contributed or distributed over the different intervention domains. And this should lead to a more visualized way to help or assist the clinicians in planning an intervention. For example, here in red, this CV domain means that here in the cardiovascular risk factor domain, there is a lot of improvement possible. And here we could focus on delivering a digital intervention based on this domain, more focused on this domain, let's say it like this. And actually in the physical activity domain, the patient is quite doing good. And here we do not have to put efforts in, because he is quite good situated actually. And to the final end, this should basically lead to an initial recommendation of the initialization of our intervention. Here we have our recommendations for the intervention pathways we are using within the Lethe framework. And basically, green means there is a standard procedure in delivering some notifications via the mobile app. And in red means, okay, here is some improvement necessary. And we are focusing on this domain, like putting more notification, more tasks, and so on. And the orange one is a middle thing between. So, and also here on the right, you can also see how the other model, like predicting the cognitive trajectory, could be integrated in this risk profile to further assist in planning this intervention. Okay, so far this initial risk prediction model focused only on an actual information during our intervention, but we have a lot more data in Lethe, which is basically in our retrospective data from all 4 clinical sites. And I just want to give you a big picture how we could manage the patient flow to our intervention application in a more product context. And here you have on the right all available models which could be or are trained in the Lethe project. And let's say here one person comes into the memory clinic and wants to get a cognitive status assessment. For this also we have a classification model classifying people in cognitive normal, subjective cognitive normal, mild cognitive impairment, and dementia. And this guy here got a cognitive status of cognitive normal, which is good for him and also good for the Lethe study, because after checking for some inclusion criteria, he could be put into our study. And then in this study, the Lethe AI models for the intervention part, like this initial prediction model, could work. This woman here will probably get an SCI or MCI classification, and then a risk conversion model like we heard basically today could identify if there is a risk for conversion to dementia. If yes, we could also try to use our lifestyle intervention to delay this probable conversion, and so this person could also be integrated in our intervention setting. And we also have some converter assessment models trained here in Lethe, but this was not part of today. And lastly, the guy here got a dementia classification, and maybe in future work we could also classify for possible dementia subtypes, but we have to investigate if this is possible with our retrospective data. But here basically you have an overall picture of the planned AI activities and in Lethe, and as you can see, basically in line with my colleagues before, there is no model to rule them all, but rather several different models aimed for a specific task within our Lethe framework. And with that, I'm at the end of my presentation, and thank you very much for being here today and having the opportunity to present you the Lethe project AI.
Thanks, Marcus, for your insightful talk. And thanks again to all for our fantastic speakers. Now, I would like to open the floor to the panel discussion. So I invite all speakers, please, can you turn on your camera? I know we already have few questions in the chat box, so I would suggest to address this question first. So I'm just looking really for a question. So yes. So maybe let's just start with our first speaker, Anna, because I see there's one question for you. So I don't know if you can read the question, but I will also read it. In having the accuracy tool as a method for empowering estimation for clinical decision making, do you anticipate any reluctance amongst clinicians in its use and applicability in the practice? In many countries, AI is still very uncertain. So how best to use this in practice?
Super. You can hear me okay? Yeah.
Yes.
Okay. Yeah, I would hope so that people are reluctant to use AI. I'll say it's probably not a good advertisement, but I want people to be reluctant and I want people to be skeptical about using AI in medical contexts, because what we've seen in recent history, when it's gotten out of the lab, so to speak, and for example, social situations where, for example, in the Netherlands, one of the governments had to actually go in disgrace because they used an AI system to evaluate social services and stuff like that. And that completely failed and discriminated against people by proxy. So what I would say is that I do anticipate it and I hope for it a little bit. And I hope the remedy and plan on the remedy being actually showing good results and showing how you mitigate those sort of biases in AI systems that very easily can creep into your AI system through your training data, which might be biased itself, or because you haven't checked all of the different correlations that can creep into your data when you go to the real world. And there, I think both the AI Act that has recently come out does quite a bit of work to actually ensure that there are at least some guidelines. I think it should still go further when it comes to regulation-wise, for what you have to show, what you did during your development, and insight into your actual both development of the AI systems and in your training data, which I think is important and which is in part addressed by the AI Act. But so yes, I would say that there will be reluctance, but I think the antidote to that is to actually show transparency, first of all, and actually show that your results are doing what they want and what you want them to do, and that you actually have proper documentation for that. Because a lot of the time, like especially with the big AI, it's a lot more nebulous, whereas at least with these sort of projects, what we're seeing here is we're still ambitious, but at the very least, we can clearly show like we have these results from looking at these post studies after we've developed our tools. And then we can actually say these are the accuracies, and we can compare to more traditional diagnostic tools like MRIs and X-rays and stuff like that, where in the end of the day, there are going to be errors. We see that when an X-ray technician looks at your X-ray, there might be an issue with him just being tired or her, and that might lead to errors. And we're never going to go to 100.0, but we can at least show what kind of accuracy and robustness we have in our models.
Thanks for this comprehensive reply. Thanks. Antti, as our second speaker, so the next question goes to you. What countries are involved in the retrospective data cohort? Are there any issues with having a non-diverse population? What do you think?
So the models will be developed using data from Sweden, Finland, Spain, France, and Germany. And are there any problems? I really cannot speculate on that. We haven't done enough work with the data. And well, we hope to get answers in the study. So when we evaluate the models, we will have data from 4 countries that are not involved in the model development phase. So it will be from Slovenia and Netherlands and Denmark and Norway. So hopefully at the end of the study, we will have some actual answers.
Okay, thanks, Antti. I will just move to Marcus because there is a similar question about the diversity. So one question for you, Marcus, it's does the retrospective data take into consideration people with a diverse background, so people with a different gender, ethnic, socioeconomic background? And do you think if there's any potential gaps in adding this retro data from this diverse group to a machine learning program? What do you think?
Yeah, actually, in our retrospective data, we have, of course, the gender information, which is present in the clinical data as default, basically. But I think in the initial memory clinics, there is some information about ethnicity and socioeconomic background. But in the harmonization because it was not present in all of the clinical sites, and in harmonization process, I think it was removed. So in the harmonized data sets, we do only have I think that the gender aspect included. But I think the strength here is that we have the diverse distribution of people over basically across Europe, because we are covering different countries, at least, like Finland, Sweden, Italy, and Austria. And so we have basically all what comes to the memory clinics is reflected here in our retrospective data. But of course, there is a potential bias here integrated in our data.
Thanks, Marcus. My next question goes to Sophia. Did you had any problems with people wearing the Actigraph regularly? How many nights they needed to have it?
Not really. So, like, since our clinical study was performed with participants that were consenting to participating there and were really looking for providing good data, we did not really have problems. They wore it for 10 days, but as I indicated in the slides, we also had historical data of other devices, so other smartwatches of about 4 weeks or 8 weeks, actually. And it's really, it depends on how long patients wear the device, of course. And the longer, the harder it is to get good data.
Okay, thanks. I can ask you another question, Sophia, just to continue with you. So we have one comment. Thanks for your talk. It was really interesting. What do you think more about challenges, barriers to this broad implementation? What is your take on the broad implementation of the project results? Can everyday smart devices that track sleep activity help to identify people at risk of dementia?
Thank you.
What is your view?
So I think that is a great idea to use exactly these everyday smart devices just because they're accessible. And they are consumer devices, so they can be bought. And the problem is, of course, that with consumer devices, we cannot really access data from the company. So the problem is rather getting large data on patients who are wearing this over a longer time to develop our algorithms and train our models. I think it is always taken to be with some care or some consideration, because it is a risk assessment, right? We have a likelihood, a prediction, and it is not a diagnosis, not at all. So this will never replace any diagnosis by a GP, by a doctor. It is just an indication of potentially there is a risk that you are developing some dementia due to Alzheimer's disease because your sleep behavior changes. So that should always be a way of saying, please go check in with your doctor, because we, via some machine learning algorithm, we can pick up patterns that you probably didn't even notice, but we noticed it. And so that's a good indication for you to just, check it up.
Thanks, Sophia. So I'm just looking at the time, so I will try just to ask a quick question to Antti and Anna before to close the webinar. Antti, the project looks quite focused on EEG and MEG data. Is this also part of the model, or are goals 1 and 2 really independent?
Was this maybe question, Marcus?
I think it was focused for you.
Because we are not using EEG and EMG data.
I think Aina is using EEG and MEG data.
Oh,
so maybe it's for Anna. Yeah, so I think it's a mistake when it was written. But Anna, if you can.
I would like to have it, but we haven't.
I think my connection dropped out for a moment there. But so question about EEG, MEG, and the development
Yeah, the project
What we
looks
use for
quite
the model.
focused on EAG and MEG data. So is it also part of the model, or goals 1 and 2 that you presented are really independent?
Yeah, that's part of the healthy skepticism, I think. So what we do with the EG, MEG, so it's used in both of the tools, if that was unclear. But the second.
So I think we lost you, Eno. Yes, I think we lost him. But yeah, I'm just looking the time. So we are now running out the time. So I would like to thank you, all of you. I will close the webinar. I know there's still few questions that we had, unfortunately, not the time to address all of them, but we will be in touch with you all. So I would like to thank all our 4 excellent speakers for today, all of you for attending today's webinar. The recording will be available after the event on the Lethe website. So please have a look on the website. You will also be able to have a look on the upcoming webinar. It will be in February or March. So thanks again. Have a wonderful day, and we look forward to seeing you again soon. Bye. Have a nice day.